All right, so we're going to talk a little bit about indications for the lateral approach. Here are my disclosures. It's just a brief background. So lateral surgery has been around for a long time. It's well described. It's a great treatment option for numerous conditions. High fusion rate through the use of a larger inner body, great indirect decompression. It is truly minimally invasive through a very small incision. It's great for obese patients, again for that reason, but also because their obesity tends to fall off the table. Very few times I've seen people who are actually obese enough that they've stayed really deep on the retractor, which has been a bit of a surprise. We've maxed out our retractors, but more often than not, that abdominal obesity falls out of the way. So it's a great surgery for those types of patients who have a lot of abdominal obesity. You can use BMP2. It's very common for adjacent segment disease and also for the reduction of spondylolisthesis. In terms of the patient selection, just sort of the basics, again, we talked about the obesity there. Prior surgery, so patients who've had a prior laminotomy and now have some residual foraminal stenosis, I think this is a great surgery for them. It also gives you an opportunity to avoid a lot of the scar posteriorly and to get a good indirect decompression rather than a direct decompression through scar tissue or prior areas where they've had surgery. I think you can also overcome a lot of patient factors. So smokers, that you have to sort of look at the patient as a whole and determine the number of risk factors that they have. But I think that getting a larger inner body in there, it can help you overcome things like smoking, diabetes, steroids, some of their medical issues. The one caveat to that would be osteoporosis. I think you have to be a little careful with the lateral, especially with expandables or if you're going for an aggressive indirect decompression. I do a lot of the expandables and try to get and then also try to get a really good indirect decompression. I think you got to be careful with that because you will get a little bit of cage subsidence. Whether or not that's clinically significant kind of remains to be seen. That's still an area of future research, but that's something to watch out for. A lot of times too, you can look at the end plates, and even if they have clinically diagnosed osteoporosis, whether that's through a DEXA scan or some other test, you can also see if they've got real sclerotic end plates, you're going to see that they're going to have the support for the lateral inner body. And so you more often than not, in times like that, you're going to be okay. If you don't see that they have that sclerotic end plate, or if they're just in general looking very thin on their X-rays in terms of their bone density, that's a sort of a red flag for you for this particular surgery. In general, when I get an X-ray, the first thing I tend to look at is, okay, there's a 4 or 5 spondy. And I'm usually thinking of how can I not do a T-lift, and I know a lot of people do T-lifts. I do a lot of T-lifts too, but in general I kind of like to avoid it if I possibly can. The reason for that is it takes a lot of pressure off me later if I can put it in a nice lateral inner body, which in the reality the whole thing from the setup to the takedown is under 30 minutes. It takes the pressure off me for the posterior side. Maybe I don't have to do as much work on the back. I know I've got a high fusion rate. I know I've got the foramen decompressed. So I'm always looking for ways where I can do an anterior or a lateral. If I can't, I can't. But the crest is usually sort of the first thing I look for. Is this going to be in the way, and if so, how much? I like to see it, ideally as low as possible, but once you get up into the mid-body of L4, I think you're running into a little bit more trouble in terms of fighting that crest and how bad you really need to do a lateral for those patients. And really for a lot of the lateral surgery, I think most people would agree that L3, 4, L2, 3, these are sort of great levels for the lateral with a small psoas. It's easily accessible. But 4 or 5 is kind of the crux of this surgery, where it's sort of like this is the more controversial area where not as many people are doing it, or there's more options, certainly. Also look at the coronal deformity. And then I try to look at just sort of an idea of the trajectory of where the crest is. And people have, I don't know if this has been looked at, I don't know that it has, but a lot of times you see people who have a real high crest posteriorly, less anterior. There's sort of a different morphology to their crest, and then how you're going to fight it is different for every type of a case. If you see that it's real high just posteriorly, a lot of times you can do a little more of an anterior to posterior approach, or like sort of ATP approach intraoperatively. If you see that the crest is high the whole way, that's going to be a little more of a challenge. Looking at the MRI, look at the psoas to determine how anterior it is. The more anterior it is, the more it's sweeping the nerve anterior and it's bringing it right into your dilator as you're putting it down. Oftentimes you can see the nerve, and if you follow it carefully through the different slices of the MRI, you can actually follow different nerves and sort of see where they're going to end up. And you don't have a great idea because there's going to be through a plexus, but it gives you sort of a rough indication of kind of where things are going to be. The size of the psoas, I think real big psoas, it's not always a problem, but the smaller the better. This is a patient, again, looking at their psoas. It's swept a little more anterior, not a great lateral case in my opinion. This was an interesting case. So if you look here, you follow from the cava, you see this big iliolumbar vein coming off. And I actually looked at this after the fact because when I put my dilator in, I saw this thing just above the disc level, and my little pin was directly, it was like a millimeter from it when I put it into the disc. And so I looked back and I was like, wow, this was there. And this had to be gently mobilized the whole case and sort of retracted with a pen field as I did everything. And so I think looking carefully at this and going like, whoa, this is a huge vein that's right there. That's a little caveat and a little extra thing that you should, it's useful to look at while you're waiting for people to prep in the OR, or maybe before if you're real organized, because that could be a problem. And sure, you could probably have just packed that off or whatever, but I'd rather not do that. In terms of the crest, the positioning, I think the break in the bed is a factor. I know there's people out there who don't break the bed. I do, and I think especially at 4 or 5, sort of tucking that crest underneath a little bit and then almost pulling a little bit of traction on their left side there to really open up that angle and give you a straighter shot down to the crest or down to the disc level is helpful. And I spend a fair amount of time just sort of positioning, making sure it's perfect. Again, getting perfect X-rays, AP and lateral there. If the crest is in the way, I do expose directly onto the bone. And then if it looks like it's not going to work from there, then aggressively with the Kerrison making enough room for it. And as long as you pack that off with bone wax and then you directly repair everything over the top of it, I think the pain is very minimal. In fact, most people haven't noticed it at all, and I've done some pretty aggressive crest resections. Some people have described doing an osteotomy and then fixating it similar to like an iliac wing fracture. I haven't tried that yet, but I've seen that anyway. So as the general deal here is just minimize the disruption. So with a sucker tip and a pen field, I gently mobilize the fibers of the psoas so I can see what I need to see. A lot of times going in through the psoas, you'll get a low reading with your first couple of probes, and this is more at L4 or 5. Oftentimes if you just twist the probe, get it right down to the disc level, and you stim around, you can, let's say you get like a 4 or something on your EMG. You go to the next one. Oftentimes it'll go to a higher level because I think once you get the probe down, the nerve in the muscle kind of comes up within the muscle belly. And if you're still at a lower number, like a 3 or 4, obviously a 1 or a 2, you're probably on the nerve. That's a problem. You should probably then reposition or leave your wire, put a new wire in, take your wire out, and then sweep anterior to posterior so that you get the nerve out of the way. But sometimes even if a 3 or a 4, you can oftentimes open your retractor. And then with the longer stim probe, you can just probe around in there. Sometimes you can see nerve, sometimes you can't. But you can probe around. If there's nothing there and everything's reading fine, the retractor blades are fine, then you keep going. So you don't necessarily have to like abort if you have a low number or reposition everything. You can kind of keep going. I think a 1 or a 2 on the neuromonitoring side is a little more of a red flag. I reposition that one. Planning ahead. So approach, you do right or left. Some people prefer one or the other. Some people, I think the room setup, right, Mike, for you is the room setup. But the coronal plane deformity also plays a role for that too. Implant sizing, I tend to preoperatively plan, get an idea of the cage size, the lordosis I'm trying to get, the height, disc height I'm trying to get an idea of the retractor depth. Is this a normal patient? If so, then you kind of have your normal set of retractors. Even if it's a millimeter or 2 long, if it's ready and they have it built, then you just put it in, fine. So that again, all these things save time. If you're using BMP2, start the process of getting the BMP2 prepared before you get in before the patient even rolls back, because that takes 15 minutes to prepare fully. So that should be ready. In general, you want to minimize your retractor time. Ideally, you want to be under 20, but I think under 15 minutes is a good goal for these. Look for the location of the vessels. Look for the nerves on MRI, and then get an idea where you're going to position your retractor based on the patient anatomy. You're trying to get really good indirect decompression. Maybe put a little more posterior if you can. Are you trying to get more lordosis? You go a little more anterior. If you're going to do an anterior release, then a little more anterior for your retractor placement. This is a pre-op plan from one of my patients that I pulled up, and this was still left over on our system, so I took a shot of this. I measure their disc heights through the lumbar spine just to get an idea. Get an idea of their overall lordosis. And then I get an idea of like what kind of correction am I trying to get. Well, for this gal, we're trying to get 20 degrees. And then I measure how much room do I have if I'm trying to put a lateral in there. This one says 27 millimeters. These are a little off. And I've measured between X-ray and MRI and CT, and they're always different. But it does give you a rough idea of kind of what you're looking for. And sometimes you're surprised. Some of these smaller women, they're smaller than you think. And I think it's nice to know going ahead of time, going in, that this isn't going to be your standard like 45, 55 or whatever your standard is. It's not like a 6'5", 45. You're just putting it in. You should probably measure it ahead of time and know kind of what you're getting into. And then I get an idea where I'm going to put my centering pin, and that's that little red crosshair there of where I'm going to be putting it intraoperatively. This was the same patient. And this is just looking at the cage sizes, which you can't quite see there. But this lady was actually kind of small. So if you look at the cage that's coming in, I think that was like 18 right there. And that's small, And that was 18 by 40, I think 18 by 45 cage. And that's pretty tight. That's a tight little corridor. And then like, whoa, look at that guy. That's getting a little close, the cava. So in this particular case, I didn't do a contralateral annular release. I intentionally stopped short, and I just used the cage. And then same thing with the cage. I put a little shorter cage in. I don't need to push the limits in this particular case just because of their particular anatomy. So those are little caveats to kind of look for. So this is that patient that had the preoperative plan with a 4 or 5 spondy there, and just severe foraminal stenosis. And again, their MRI there, favorable psoas, maybe swept a little bit anteriorly, but it's nice and small. And then post-operatively, that's nearly the 20 degrees that we were shooting for. Most of it was obtained intraoperatively just with the cage. And you can see, to be critical, yeah, there's a little bit of subsidence with that cage, but not clinically significant. And again, just kind of massive correction, which I think is hard to get posteriorly, that kind of disc height. I think anterior would be the other option to get that, but really through the lateral you can get pretty powerful correction.
How tall is that cage? 16 millimeters?
The height of that, I don't know what I don't know the exact height, but probably at least. I think those go to, I want to say they go to 18. They get up there.
Fixate them both laterally and posteriorly.
I tend to always do perk screws posteriorly. The reason for that is I don't use these in a standalone capacity. Those are that's an integrated screw system, so it's part of the inner body. The screws that are in there, I didn't really go for the major distance in them. I don't know, with a spondy that high, I don't do any standalone laterals. I've done a.
Why did you put them in?
Put what in?
Why did you just use the cage itself and screws in the back?
Cage itself and no integrated fixation?
No screws laterally.
You could do that. This particular cage, so this cage is the 20-degree cage. It's only offered in a cage that has integrated fixation. So sure, you could just not put it in. A lot of times I'll put a single screw in just to help hold the position. At 4-5, if there's any question of the nerves being in the way, then yeah, I tend to try to not use that cage at 4-5, to be honest, because I want a smaller profile cage going in. That'd be less, risk of nerve injury. But this particular one where we wanted 20, it only comes in that. And so because I had the room intraoperatively to put these screws in, I put them in. I don't think it hurts. It didn't add any, it added maybe 25 seconds to the case, maybe a minute for both screws. But
Could you elaborate on your technique, because that's really remarkable, opening of that space of training. If I don't cut the ALL, I have enough time.
yeah. This one, it's an expandable, yeah. So for these particular cases, my sort of the sequence for me is I'll just make a box annulotomy as wide as I possibly can. And then with the use of just a cob, I'll kind of feel the end plates, get an idea of where I am on the inferior one, the superior one, then I'll do a release on the contralateral side. I oftentimes start with a smaller, narrower cob, and then I'll go to a bigger, wider cob, and then I'll release inferior, release anterior, and then clear everything else out with the pituitary, go to a ring curette, and following that, bring in X-ray, and then I'll put the expandable trial in. In the expandable trial, I'll check it on its way in to make sure I still agree with what I think is the center, and then swing around to the other view.
And then lastly, why lateral as opposed to
This particular patient, I think the obesity was a bit of a factor in terms of her size, but I think an anterior surgery would be another totally valid option.
You wouldn't worry about the damage in end plates. You went from 8'9" millimeter height to 16'18".
Yep.
You wouldn't worry about subsiding.
Yeah, definitely always worried about it. And another reason to put in the screws in the back to back it up. And I think if you've got a strong pedicle screw construct posteriorly, that does protect you from a subsidence event. I haven't seen any intraoperative subsidence. I haven't seen the trial just blast through the end plates or the final implant, do that either. So as long as you're careful, they do torque out typically. You have to be careful though. A lot of times with over distraction, with a high-grade spondy, I don't think you get much in terms of the over distraction. You get more of a reduction force. With the people that don't have a high-grade spondy or that don't have a spondy at all, and you put these in, you over distract, they get a lot of nerve stretch pain, similar to like you can get with an ALIF. And usually that gets better. They always get better, but that's something that you oftentimes run into.
With these expandables, especially with that much distraction, have you ever lost the ALL inadvertently?
Yeah. Oh, yeah. And I think I've got multiple cases where I think the ALL has basically auto-ruptured through the expansion process.
Nice to have that option.
Yeah, so you should put those screws in laterally.
Yeah. I mean, why not? Yeah. Yeah. I mean, I think there's enough fixation. I don't think you necessarily need the, like you're talking the lateral screw, the one in 4 and the one into 5 there.
Well, so when you do ALL resection, people worry about the graft popping out actually. So
Right.
Yeah, so you should
You should be careful with that, or a plate and screws, or however you want to do it. I think there's enough friction with the device and it's under enough tension. I think it'd be pretty rare for it to spit out the front. However, yeah, if the thing is there and you're looking at it and you can put a screw in easily, the instrumentation's nice. It's usually an angled instrument. You can put it in. So yeah, I think that it's a good option. This was another case here. So this is a guy with he's got a 2-3-3-4 problem, essentially, with coronal deformity. This was just, again, highlighting the correction you can get with the lateral. This was an open decompression at the levels that are, again, more favorable for a lateral. This was a little more interesting. So this was a lady with little 3-4 spondy, little higher grade 4-5 spondy, very degenerative there. And if you look at her MRI, just severe stenosis at 4-5. And then the psoas there, a little anterior, so it's getting kind of in the crest is getting close. So this one was, the thought was, well, we'll try for a 2-level lat. And she did have severe stenosis at 3-4 too. You just have to take my word for that. And a spondy. But this one, the thought was, well, if I can't get it through a lateral, then I'll get a little additional correction at 3-4, and then if I have to just fuse it in situ, then I've got the extra 10 or 15 degrees at 3-4, So that was kind of my approach there. And intraoperatively, and then this is 3-4, little lateral recess stenosis there. And then the frame in there, really severe at the 4-5 level. But intraoperatively, again, great correction there just at 4-5 with the lateral. And with that one, that wasn't a direct to expandable trial. That was starting just with a cob carefully. And then there's the 7 millimeter, the thin trial, and the 8, the 9, sort of the more traditional way you would go through each one and carefully try to build it up without just violating all the end plates. But again, just kind of highlighting the powerful correction you can get with the lateral inner body.
So you didn't do posterior decompression?
This one, I think I did. I did. She got an open posterior for sure. And I think I did one incision, and I did like perk screws, and then I did laminotomies through that same incision, because that's pretty severe. That one I don't do I do love indirect decompression, but that one's like, that's just too much for me I don't have that kind of courage to see what happens there. I open that up. So, yeah. But it's interesting when you open it up, you go, this wasn't as bad as I thought, because you got such great indirect decompression. So it's not as hard, So. Right. So oftentimes I'll look for any kind of, and I think on a flexion extension film I did see a little bit of vacuum disc phenomenon. So I see that, I know I can get it, and then it's moving. And she didn't have that. She had,
I'll make one comment about that. I have probably about 10 now. Patients who have a horrible 4 or 5 like that.
yep,
3, 4 kind of borderline. And you look at it and you say, okay, well 4 or 5 is obvious problem. Let me just do that. And I think it's just years of 3, 4 overcompensating for the loss of low dose of 4 or 5. And I have 5 or 6 patients, not enough to really write up anything meaningful, but they come back with a hyperacute adjacent segment disease. So I think you did the right thing.
yeah,
If 3, 4 looks borderline in a bad 4
Yeah.
or 5 spondy, do that too up front.
yeah. And this one is nice because she has a little spondy there, so it's like
Yeah, yeah.
kind of like more indicated.
Yeah, you
but-
could say, yeah, it doesn't look terrible, but they
How
come
about
back too much.
getting the pushback from the insurance company, say, you know what, you're authorized only 4, 5, 3, 4. We get that a lot in Florida.
That'd be tough, yeah. I mean, I definitely called that a spondy at 3-4, and I think that's why there was no issue. But yeah, I can see where if you're getting borderline, or if it's just real severe stenosis from adjacent segment disease, and you're like, I don't want to decompress this, and then come back in a year when it slips, So I get it.
I've noticed your lateral fixation. Have you looked at doing unilateral screws or boxing from a biomechanical standpoint with that thought process?
I haven't done any unilateral screws. I know some guys do that. I think it makes some sense if you have like the integrated fixation on one side, or you got a plate and screws on one side. Maybe you do the other side with unilateral. I don't know. I've always just put in bilateral because I just didn't want to. I didn't want to have a non-union or I don't know. I just have
More
always.
is better.
Yeah.
Yeah.
Kind of.
I've done a lot of one-level unilateral screw and haven't had
Had a
any
problem.
I think it's a little bit of the size of the cage you put in. You can get
Right.
22 or something.
Yeah.
And the dynamic nature of the spondy, it's more of a fix or something like that.
Yeah.
I trust a little bit better.
Yeah.
I'll go even a little further. I mean, I think, that the spondy case definitely needs some kind of posterior, but I think in a lot of cases where you have, not so much listhesis, but you just have really lost body, you can do a standalone.
Yeah.
I've done a lot of
Potentially.
standalones and, I haven't really had to doing that.
Yeah. I like the idea of standalone lateral. I think I've only done a couple of them, but I always kind of wish that I did more of them. Do you put a 2-hole plate or a 4-hole plate in with like 2 screws?
Put a plate next to the cage.
Just the cage.
Just a cage. And I love it for if you have, somebody has a 3-to-1 fusion or a 4-to-1 fusion, they break down above.
Yeah.
I'll just put a excellent cage in front.
Do you keep it on the brakes?
No.
Age is not a factor for you?
Yeah,
Young
age is,
you're
I mean, I
old.
wouldn't do that in necessarily 80-year-olds, but generally somebody, within their 60s, I mean, I have no issues doing that. I mean, I always give them the disclaimer that, there's a chance I'm gonna have to go in and put the fixation in. But even if they subside a little bit, I mean, I'm using BMP, and they heal very, very well.
Yeah.
I think, when I was in New York, we took a look at a whole series of these, and I think the fusion rate was well above 95%. And so, I think
I think we'll see some data. I mean, I think there are people out there that do this routinely, and if they all say that the results have been pretty good, I think they're going to put data together and we'll sort of see how that goes. But
Yeah.
it's very reasonable. We might be over instrumenting people.
Yeah. I've seen in my area, I've seen a fair number of people who've had like oftentimes it's like a 2-level lateral for some reason, and that's it. And they get this persistent coronal deformity that progresses, and then they get foraminal stenosis and back pain, leg pain. So I've seen a lot of those. So I think I've been a little biased because there's someone who's doing a lot of those just standalone laterals. So I think that kind of biased a lot of what I.
And I've seen that too. I think, that's where the biology really makes a difference.
Yeah.
So if you don't use BMP,
Yeah.
I've seen that too, where people will stick a cage in there and put some kind of synthetic bone graft. That just doesn't heal.
Yeah.
Even the osteocells don't work as well.
Yeah.
But if you put some BMP sponge in there, I think it's going to really help get that to heal, in which case you won't have that collapse that you would see.
So a couple of questions then. When do you put screws in for lateral?
But, well, I'm doing a multi-level deformity correction, right? So if it's more than 1 or maybe even 2 levels, then I'll put the screws in, right? Because then I'm asking the cage to do something biomechanically. I think I'm trying to hold the spine in a more rigid position. adjacent segment disease, and like I said, without much, front back deformity, the prosthesis, I think, is a very reasonable thing.
The second question is BAP what?
Nothing. That's
Just
it.
BAP alone?
Just BAP sponge. And usually for a 3-level, I'll take a large BAP sponge, cut it in thirds, and cut it into halves, and put it into each chamber.
I just got the signal from Innovasis that they don't want us to talk about no instrumentation anymore. They only talk about full instrumentation.
Cool.
Is that right?
All right, thanks.
Thanks, Tony.